Okay. Oh, my formatting has changed. Okay, we'll work with that. So I'm here today, and when I was looking at the program, I was very much, I've been and listened to Bruce Guthrie a few times and very much inspired by their work in Scotland, but I wanted to demonstrate here today that here in Ireland we have been doing multidisciplinary research around optimising prescribing, but also then to feed into the antimicrobial theme of today's talk. So I'm hoping to cover both, and please forgive me about my formatting, but my UCC template seems to have been dropped. Okay, just some declarations. I am part of the Pharmaceutical Care Research Group in UCC and are co-investigator in the development of the stop-start criteria, which I will be talking about. And we have received funding from a number of bodies, HRB, Enterprise Ireland, EU, FP7 and Horizon 2020 Network. So again, but there's none other relevant to this talk. I suppose internationally, the role of the pharmacist and the role the pharmacy can play in patient care has been researched, and there's been numerous international reports. But locally, here in Ireland, we had a few years ago the interim report published in 2008 that was called the Pharmacy 2020 Vision, which was looking at the role of the pharmacist in chronic disease management, health screening, recategorization of medicines and vaccinations. And we have achieved some of these goals. We have achieved them very well. And again, last week, the Pharmaceutical Society of Ireland published its Future of Pharmacy report, of which I was part of the steering group. And again, that's following on from the interim report to where is the role of the pharmacist? What role has the pharmacist in patient care? And that Future of Pharmacy report very clearly puts the patient at the centre. That is the aim of all healthcare professionals, is to optimise patient care. And it will be around minor ailment schemes, electronic health records, sharing of information, extensive medication reviews, vaccination services, etc. And again, just taking from the Future of Pharmacy report, this schematic shows the pharmacist has a role from self-care to primary care to formal residential care in long-term care facilities and also in acute services, where the patient moves from one location of care to another. For a transition of care, there is a role for all healthcare professionals. And us as pharmacies, we're very interested in medication optimization, medication reconciliation, and ensuring that the right medicines are charted for the right patient at the right time. So again, there's a key role for pharmacy in each one of those transitions. My research to date, as Mary alluded to, and has been primarily focused on the elderly, coagulation and antimicrobial therapy. And today I will focus on the elderly and our antimicrobial work. Why have I looked at the elderly? Bruce covered this very clearly earlier on. And it was mentioned also in my colleagues' talks about our greying population. Our population is growing older, they're living longer, they're living healthier, but they're living with more multi-morbid polypharmacy issues. There's a potential increase in the prevalence of disease, unique medication needs. As you get older, your body's ability to clear and metabolize drugs from our system alters. So the effect of a drug in the body in an older person is different to that of a younger, fitter, healthier individual. So again, there's an increased prevalence of adverse events and that are causal or contributory to admission in hospital in the elderly people. And I'll show some of that in a while. But we've been looking at potential inappropriate prescribing, and that is where the potential risk outweighs the potential benefit. And it might be over-prescribing or under-prescribing, where potentially beneficial medicines are not prescribed. And in some situations, that can be as high as 30% of people are not prescribed a potentially beneficial preventative treatment for their list of disease states. But it's also drug-drug interactions, drug-disease interactions, and maybe too high a dose for too long a period of time. And I will be talking about this tool. It's called the Medication Appropriateness Index, and it's a tool that is used to quantify how appropriate medicines are for a patient at a given time. And it was published by colleagues in the United States, and it's a summated score of a total of 18. And the higher the score for patients, the more potentially inappropriate or the less appropriate the medicines are. The lower the MAI score, the more optimum patient care is. So I will be referring to MAI, so just in case you haven't heard of it before. Internationally, two pharmacy colleagues, Anne Spinawina and colleagues in Belgium, and Ulrika Gillespie and colleagues in Sweden, have demonstrated that pharmacists as a multidisciplinary team member in the hospital setting can improve the patient's MAI score and reduce the returning visits and reduce all-cause mortality and healthcare costs. So when we were working at developing a HRB grant, as we all do, and you try to submit that grant and you do get more rejections than you do get positive results, but we were looking at this and we said, well, really, it's the multidisciplinary team. It is the pharmacist working with the physician in optimizing the prescribing and communicating that is where we want to go and where we want to look. So Kieran, one of my PhD students, did a systematic review of and meta-analysis of pharmacist intervention studies in acute care settings and what impact did this have on patients' MAI scores. So the forest plots here demonstrate, the summated forest plots demonstrate that from these studies of pharmacist interventions in acute care elderly patients, there was a statistically significant improvement in the patient's MAI score at the point of discharge. And the lower plot here shows the difference in patients' MAI score from the point of admission to discharge. So if you look at just at the point of discharge or during their hospital stay, the interventions have a statistically significant positive impact on patients' medication appropriateness. So I mentioned earlier on that I'm part of a team that developed the stop-start criteria. And the stop-start criteria are a list of criteria listed by physiological conditions. They're designed for use in the elderly population, 65 years and older, to try and flag to prescribers and healthcare professionals reviewing medicines potential inappropriate situations. They were first published as a full set of criteria in 2008, and we have updated them recently in 2015. And we have had a number of conference publications and other research papers with these criteria. But if you look at primary care levels, so we did point prevalence studies in both nursing homes, secondary care and long-term care facilities. And those rates of inappropriate prescribing vary from 20% to potentially 70% of patients experiencing one or more instances of potential inappropriate medicines or prescribing omissions. And again, this is just the nursing home studies where 13% of patients had one or more medicines that were potentially inappropriate, but it affected 70% of resident populations. Equally, 50% of people were omitted a potentially beneficial medicine. So again, it's taking both hand in hand and looking at where there is a potential role. And again, we've demonstrated that as pharmacists, both in hospital and community, can deploy these criteria, and the inter-rater kappa coefficients are equally as good as the gold standard clinical geriatrician deploying the same criteria in the same set of cases. Is it a big problem? What is the situation? And again, with colleagues Hilary Hamilton and other geriatricians in CUH, we've demonstrated that 26% of the admissions through the emergency department of CUH, of the elderly admissions, are associated with potential inappropriate prescribing. So the drugs are causing or contributing to 20% of those elderly patient admissions to CUH. and the stop criteria were 1.8 times more likely than the Byrne criteria, which is another set of criteria for prescribing in the elderly, to identify this potential error. So we wanted to look at what was the impact of pharmacy, what clinical impact could pharmacy have, and what economic impact could pharmacists have. So, working with David O'Sullivan, we looked at establishing a structured pharmacist medication review at the point of admission in the emergency department of CUH. And in this point prevalence study, we followed 361 patients over a 13-month period. And we looked at the MAI and ACOVE scores, and also whether physicians were willing to accept the interventions and the recommendations made by the pharmacy team. So there were 1,000 medication reconciliations identified in 296 patients. That is 82% of the patients being admitted through our emergency department had medicines reconciliation problems. 58% of the pharmacist's recommendations were accepted, which is quite low, but again, I'll come on to reasons of that in a minute. When we looked at what were the reconciliation issues, there was appropriateness issues, but there was also reconciliation. So nearly 70% of the issues were reconciliation, whereas indication, interactions, renal adjustment, and again then whether medicines were potentially inappropriate were our key recommendations. And potentially, I think our recommendations, acceptability of our recommendations being in the order of 50% was low because we tried to do too much. We tried to do an appropriateness review as well as a reconciliation, where I think if we had focused just on one aspect of those, we would have achieved higher acceptance. We were overloading the behavioural change wheel, and we used the MITGE behavioural change wheel model, has demonstrated to us that we were giving too much. Our barrier is our report. We are providing the clinicians with too many decisions to make, whereas with more streamlined interventions, prioritising those interventions for the clinician would have resulted in more acceptable uptake rates or higher uptake rates. Again, though looking at the MAI, we showed a statistically significant difference in our MAI scores at the point of admission to follow-up, which was days 10 to 14 during a hospital stay, or earlier if they were discharged before 14 days. We continued this work on in a cluster randomised controlled trial, where we randomised 376 patients to the control arm and 361 to the intervention arm, and again looked at MAI and adverse events. How many adverse events were occurring in these patients during their indexed hospital admission? We also looked at secondary outcomes such as all-cause mortality and hospital stays. In our intervention arm, 61 adverse events occurred in 50 patients compared to 91 in 78 patients. So we had a relative risk reduction of about 6% of adverse events occurring for our patients. And again, whether they were contributory or causal to admission is listed there. So the key take-home message from me was, for every 15 patients screened by a clinical pharmacist at the point of admission to hospital, you will avoid one major in-hospital adverse event. And again, the next question was, there was no difference in length of stay or all-cause mortality. So our key outcome there was a reduction in adverse drug events occurring during the 14 days of hospital stay. Then economically, was it worth the investment? And again, two papers published by another PhD student, James Gallagher. The first paper was a probability paper that we demonstrated from the pharmacy staff in CUH. Prospectively, we followed their interventions over a 12-month period, and we calculated probability scores of adverse events occurring, the recommendations and the impact of those recommendations. And the effectiveness, the cost effectiveness of those interventions equated to, for every one of those hospital pharmacists, they saved the hospital budget €80,000 over and above their salary per annum. based on the interventions. But we then had the key opportunity as well to take the prospective RCT study and see if there was a cost effectiveness analysis to be done in this prospective RCT. And again, based on the cluster randomized trial that I described earlier, we used these costs. We estimated that the costs of the pharmacist's time, the non-consultant hospital time during the consultation with the pharmacist to implement, hospital bed day costs, and also software costs used in the intervention for development. And again, in cost effectiveness analysis, you calculate the ICER score. And for those of you who don't know what the ICER score is, it gives you a lovely graph. And the graph basically tells you it's cost effective if it's in the right-hand upper quadrant or it's dominant in the right-hand lower quadrant. If it's in the left-hand side of this graph, it's not cost effective, and there's questions to whether your intervention is actually clinically effective as well. So luckily for us, the cost effectiveness is here. It's in the dominant and cost effectiveness quadrant. So again, the structured pharmacist intervention with a dedicated software screening tool demonstrates statistically and economically to be potentially beneficial, not only to the patient, but also to the healthcare system. And again, they're very positive outcomes to where the role could be deployed and expanded. So leading on then to sepsis and antimicrobial stewardship, as was mentioned in the talk, I was part of the multidisciplinary team that developed the guidelines for primary care antimicrobial usage, and I met one of the lead individuals earlier on who told me I should have had the new website up there. There's a brand new website, Nuala, isn't there? So I should have had the new website, Antimicrobial Guidelines, and it's very much an interactive website to aid prescribers and healthcare professionals to make sure the appropriateness of antibiotics are being chosen and used appropriately during the stay, during the initiation process. So some of the work we did, and I've chosen just, again, keeping on the theme of hospital and the role of the pharmacist, work that one of my PhD students, Aoife Fleming, did a comparative study between the UK and the Republic of Ireland, where we did a cross-sectional survey designed approach, looking at antimicrobial teams, antimicrobial stewardship processes, and benchmarking ourselves to the UK and Ireland. Because again, for ourselves as healthcare professionals, we need to audit, we need to benchmark, we need to continuously improve. We can't stay stagnant, we have to continuously improve and move forward. So again, this was a multidisciplinary survey looking at antimicrobial management teams, antimicrobial stewardship policies within hospitals, and then to look at the structures, the processes, and the outcomes of these going between Ireland and the UK. The aim was to compare and conduct nationwide surveys here in Ireland and compare the findings. Ethics approval was sought and gained. Two postal surveys were developed and piloted in the UK with reminder follow-ups. Surveys were also distributed in the Republic of Ireland to all antimicrobial pharmacists or chief pharmacists within the hospital networks. Surveys were conducted in 2011-12 in the NHS and in 2012 in the Republic of Ireland. We had a phenomenal response rate from the Republic of Ireland. We had a 73% response rate, and again, showing both a private and a public mix of hospitals, whereas in the UK, they were all NHS hospitals that replied. We had no private hospitals in the NHS that replied. Interestingly, 57% of the Irish respondents said that there was an antimicrobial management team in place in their hospital, versus 82% in the UK, and the majority of hospitals had antimicrobial prescribing guidelines and policies in place, 88% and 98% relative in the UK. So again, just looking at that, again, Whether a pharmacist was part of the AMT, it was close to 70% here in Ireland versus 95% in the UK. And again, there was less infectious disease, consultant infectious disease involvement in the Republic of Ireland versus the UK. So again, these are just benchmark parameters, and again, I would be advocating opportunities for development and improvement going forward. Interestingly, from the survey, the key function of the antimicrobial stewardship team in Ireland was looking at the volume of antibiotic usage. Some sites were looking at the appropriateness of antibiotics with regard to the indication, and others were looking at the restrictions of antibiotic policies and the appropriateness of restricted antibiotic usage. But they were in the 50s. They were 58% and 52%. Again, they're key opportunities with regard to antimicrobial appropriateness and effectiveness, where roles could expand, future research could look at to ensure that the use of antimicrobials are much more appropriate for the indication for sepsis treatment, feeding into the sepsis care pathway, and again making sure that the appropriate antimicrobial is chosen for the different stages of sepsis on that form. Feedback to prescribers, again, the UK were ahead of us on that. Again, some sites in Ireland provided ward-based feedback or individual physician-based feedback. But again, it was suggested through qualitative work that maybe automated prescribing or electronic prescribing systems, if they were implemented and deployed, would make that much more readily available to the team, to the ward, and also to the physician with regards to their prescribing. So again, just looking at some of the key qualitative points that came up. So some of the qualitative statements were, locally we need to finalise guidelines and then begin to develop our audit and feedback process. Electronic prescribing would make monitoring much easier and give immediate feedback and effective in changing prescribing patterns, again feeding into the process issues within our healthcare system. If we were to look at key strategic issues for Ireland, one of the quotes was that despite repeated attempts to put antimicrobial stewardship teams in place, it has not happened. We need a microbiologist to push things forward. So again, identifying potential barriers that exist within the healthcare system. It may be difficult to progress programs without ring-fencing resources, need to implement antibiotic guidelines. So again, individuals identified that there was other pulls or other strains put on their time, and they weren't able to dedicate their time to antimicrobial stewardship as they would like to. So again, structure and process issues within our healthcare system. So finally then, important differences were found in the antimicrobial work between Ireland and the UK due to lower numbers of antimicrobial pharmacists and Irish antimicrobial teams. There's a lack of resources dedicated, and it does have an economic impact. Research has shown that for every €3 spent by pharmacy, for every euro spent, there is a €3 return in the antimicrobial stewardship campaigns within healthcare systems here in Ireland. Continued support is required, continuous improvement, feedback to teams, improving prescribing feedback would be one of the key issues. Providing individuals with specific feedback on their prescribing would be very important, and their choice of antimicrobials would lead to more choice of more narrow spectrum antibiotics and improve patient care into the future. So finally, I'd just like to thank you very much. Mentioned the Senator project. Senator is a European-wide multi-centre funded EU project looking at potential inappropriate prescribing in the elderly, and again we would hope to have the results taking our stop-start work European-wide to 6 European centres, and that should be published within the next 18 months to 2 years. So thank you very much, and to thank my colleagues.